you want the mic for the voice to that's one of the problems I've been talking about. The throat's going.
And that's why we're so, okay.
Yeah.
So you might need to, okay.
You actually got to say, where are these children? I'm surprised that we had as big a number as we have.
Okay. You don't use this.
We'll probably double mic you. The CME needs a mic, and then we can do one for the room so we don't have to shout so much. Okay. That'll be better for your voice.
Are we wearing out your vocal cords there?
Yeah, a little bit.
The end of the last talk, but
So you've been in Richmond for a good while.
a very long time, yeah. I was just saying, I never would have predicted I would stay there. So my husband is also at VCU, an academic.
Oh, is he really?
Right. And so we both made our careers there.
Oh, yeah, no. Well, I have a son. I was just on the phone to him yesterday. He's a 20-something working in Chicago. And he's talking about how his company may move him to Richmond.
With that number that's on the board, or
I don't know anything about Richmond. It's a great place. Couple hours
want
from
to sign in
DC.
with that number and put the event code in. If this is the first time you're doing this for CME2,
Oh, good.
ETSU, then at some point during this week, you will get a text from them trying to identify your number to your name. And then going forward,
He
there
has
will
no
be
business raising a family yet.
This is the way we count our numbers for grand rounds, so please fall into that number, because otherwise we lose certification if we don't have our grand rounds. The other big piece for CME is that we do complete evaluations at the end of the talk. So please make sure, we've set evaluations at all the tables, there are more up there. Please make sure. I just wanted to make sure everybody's signing in for the talk. We have a few minutes before we get started, but just wanted to do everyone. Thank you.
So definitely more for the room. And if you don't stray too far from this one, that'll be fine. Good. Press and hold. Say something.
Hello.
Perfect. Sounds good. This should be something we're going to pick you up within a few minutes. But I don't want you to worry.
Yeah. Okay.
Don't worry, you can't use that.
No.
Plug this in there, because I don't want to
Our lunch line is coming to a reasonable level here.
It's mic on YouTube. Is this the one?
much more sensitive that we don't have to wear 2 mics.
Oh,
I'm going to stay in this area.
So I'd like to introduce our speaker. The line is getting shorter, so if we can get our lunch and sit down and allow Dr. Irani to get started, because I know she has a lot. She spent the whole morning already teaching us, and we look forward to more case presentations and discussion. But I just want to make a brief introduction. Dr. Irani comes to us from Virginia Commonwealth University in Richmond, Virginia, where she's been there for a while. She did her undergraduate and medical school training in Lebanon at the University of Beirut, and I assume you're Lebanese then?
I am.
There you go. So after that point, she came to the United States and did some fellowships and research fellowships, went and did a residency at Virginia Commonwealth, fellowship at Virginia Commonwealth, and has been there at least 10 years. So,
30. That's okay.
yeah, no, I mean, we're talking, yeah. But she's a very, very respected leader in allergy immunology field. She's been a board member for the American College of Allergy and Immunology. She's the chair of her department at Virginia Commonwealth, and she's has a CV that I couldn't print out. It was way too long, with grants from NIH, other types of industry-sponsored grants, as well as numerous publications. So we really appreciate her taking the time to spend a day and a half with us here, and I know we're already benefiting, and I want to thank you personally for coming, and I look forward to your talk.
Thank you. It's been a pleasure. Okay, so we're changing gears a little bit. We've been talking a lot about food allergy, drug allergy, anaphylaxis, urticaria, and I want to talk a little bit more about the immunology of asthma. This is not at all about how to treat an asthma exacerbation. The way I like to present it is really how to never have your patient end up in the hospital. So it's more the knowledge behind the immunology of asthma that might help you decide how to treat. As pediatricians, I'm sure that you all get the same question. When you make that diagnosis, the first thing the parents want to know is, but my child is going to outgrow it, right? And so let me tell you a little bit of what we've learned about this topic. So these are my disclosures. And the only thing that may interfere with this presentation is that I'm on the Speakers Bureau for Merck, and they do make some of the medications used in the treatment of asthma. So my objectives today is to really cover a couple of areas. One is to show you a tool that we actually can use in the clinic to help us make the diagnosis of asthma in very young children who are too young to really be able to do lung function testing or some of the other tests that we can do to help us in that diagnosis. But I really want to focus on this question of, well, what happens to the child with asthma if you don't do anything? And do we change that natural progression with the therapy that we have available? That knowledge is actually going to put in perspective the current guidelines from the NHLBI, which are overdue for an update, and actually the committee is being put together as we speak to update the NHLBI guidelines. So let's start with an infant. And we all know that when infants get viral illnesses, they often wheeze. These wheezing infants who wheeze with viruses, about 60% of them don't have asthma at all. And so these kids, by the time they're 6 or 10 years of age, are no longer wheezing. And this is what led to the old belief that most kids with asthma will outgrow their asthma. That's not exactly correct, because these kids did not have asthma in the first place. And so I like to use the term transient wheezing for that condition rather than the term asthma. However, that means that about 40% of these infants that wheeze when they're having a viral infection actually have early onset asthma. And these are infants who are going to go on to have persistent wheezing into their later childhood, adolescence, and adulthood. So the big challenge for us is, can we recognize them? Can we tell them apart? And one big clue, of course, is the presence of atopy. And what this chart is showing you is that in addition to these transient early wheezers that we talked about, that wheeze early on with viruses and then stop wheezing by the age of 6, we have the other two groups that are continuing to wheeze, but if they're atopic, they tend to continue to wheeze past the age of 11. If they're skin test negative and you can't really demonstrate that they're sensitized to any allergen, these are the ones that tends to actually go into full remissions later on. So I'm going to summarize a whole lot of work by showing you this pie chart. This is work by Fernando Martinez, who initially started a cohort at birth of about 1,000 children, a little bit under that, 826. And these were all comers. And his question was very simple. The best way to do research is to do prospective studies. So you start with the kids and you accumulate a lot of data. You have their family history, you do skin testing, and you watch them and you see what happens to them. And this study was published in the New England Journal. At the time, the cohort was 6. That cohort is now in their early 20s and still going. And so what he found at that time is that if you take a look at all these 826 children, about half of them never wheezed. But that means that about half of them actually had some wheezing in the first 3 years of life. And if you look at the wheezers, then you can actually divide them into another 3 groups. These are the kids that wheeze in the first 3 years, and by 6 years are no longer wheezing. These are the kids that actually start at 3 years. So it's not very hard to figure out that these are asthmatics, because they're not the babies, okay? But these are the babies that wheeze early on and are true asthmatics. So you can see that our dilemma is between these 2 groups. If you start wheezing before the age of 3 when you have a virus, you have about a 60% chance of being a transient wheezing and about a 40% chance of being persistent. Now, remember, they collected the data prospectively. So at 6 years of age, the researchers were able to ask the question, could we have predicted in the first 3 years which of these kids would still be wheezing at age 6? And they had all the data. So they went back, and this is what they found. They found that they actually could develop a very strong asthma predictive index. And you're going to see that term in the NHLBI guidelines, API, for asthma predictive index. This is more than a theoretical slide. This is a tool that I think you should use in your clinics every day when you're trying to figure out what to do with these kids. And what this actually says is that if you have a kid under the age of 3 who's wheezed several times, if they have either 1 major criterion or 2 minor criteria, they have a very high increased chance of being persistent wheezers. Now look at the criterion and you're going to see your atopic child, right? It's mom or dad with asthma. Now it doesn't mean that a brother or an uncle is not a risk. It's just not strong enough to make it into that asthma predictive index. So it has to be mom or dad with MD diagnosed asthma, or if the child himself or herself has MD diagnosed atopic dermatitis. So not a couple of little lesions or keratosis on the arm, real atopic dermatitis. And finally, a positive skin test, usually to an indoor allergens, because at that age, they're too young to have been sensitized to pollen. These are the major criterion. The minor criterion initially was allergic rhinitis. Now it's been replaced with food allergy, peripheral blood eosinophilia, which you may or may not have because we don't always get a blood work on these kids, and then wheezing when you don't have a cold. Because think about it, the whole concern is it viral-induced wheezing only, or is it real asthma? So if they wheeze when they're running around, or when they don't have a cold, or when they get exposed to the cat or the dog, then clearly it's telling you it's not viral-induced wheezing. So how good is this asthma predictive index? So if you take a child who has had frequent wheezing, which is defined as more than 3 times, their risk was 10-fold increase. So if you think of a prevalence of asthma of about 8.5%, they had an 85% chance of wheezing at the age of 6. Now, if they have only 1 episode of wheezing, that's called a loose criterion, a loose index, and they were up to 5.5 times as likely to be wheezing. But look at this. This is also very helpful. This is the theme of negative. We talked this morning about negative skin test being a very good predictor of not being allergic. If you have a negative asthma predictive index, you've got a pretty good chance that you don't have persistent asthma. And that, to me, is almost the most helpful part of the asthma predictive index. So you see these kids that wheeze every time they have a cold. Neither mom nor dad have asthma. The child doesn't have eczema. You've skin tested. The skin test is negative. The kid only wheezes with viruses. If you have a blood count, there are no eosinophils, and they don't have food allergy, the chances are very good that by the time the kid is older, they're not going to be wheezing. The other thing that that study showed is to kind of explain to us what transient wheezing is. And so we're going to move on to the natural history of asthma. This is the same cohort. This is the Tucson, Arizona cohort of Fernando Martinez, and they're now being followed up till the age of 17. And what they did, in addition to the clinical criterion, the skin test, they also collected lung function measurements. And of course, the way you do that in young kids, they can't do spirometry, so you do this compression maneuver where you press on the chest, and as you let go, they have some transducers that measure pressure. Don't ask me anymore, I don't do these tests, but they were standardized and they did them for all the groups. And so this tells us a lot about what's actually happening, because some of you might be asking, well, what is transient wheezing? Why do they wheeze in the first 3 years and not later on? So look at the group. These are the control group who never wheeze. So that's kind of your standard, right? If you look at the transient early wheezer, look at that. They actually start quite low. They start lower than all the others. And then as they get older, they're kind of catching up. What we think transient wheezing is actually a simple anatomical issue where you are born with airways that are smaller in caliber than others. Now, if you already start with small airways and you get a viral infection with a little additional swelling, now you get to a critical diameter where you wheeze. If you take that same child and they're now 6, 10, or 20 years old, they still have airways that are smaller than the general population, but by virtue of their size, they now have plenty of room. They can have viral infections and they won't wheeze. So we think that transient wheezing is more of a mechanical thing. Now, the other group we're interested in is the persistent wheezers, right? It's those babies that wheeze in the first 3 years of life, and then they keep on wheezing until age 17. And look at their lung function. In the first year of life, remember, this is a prospective trial. These kids were measured before they had a lot of wheezing. The first year of life, they're pretty much the same as the late onset and not significantly different from the never wheeze. There's not much difference here. So what that tells you is that persistent asthma is not a congenital lung disease. You are not born with abnormal lungs. But one question we've often asked is, do you lose lung function when you have asthma? And when I was a resident, we used to say, yeah, you do, but it takes 20 to 40 years, so we pediatricians don't have to worry about it. And what the study showed is that by the age of 6, this group was now statistically significantly lower than the control group. Now, remember, we don't have points in between, so we don't know when that happened. It could have happened after the first exacerbation, for all we know. And also, this is a mean. And we talked a little bit this morning about mean and the bell-shaped curve. So I don't want you thinking that every kid who wheezes in the first 3 years of life who has a positive API is going to lose lung function. No, this is a mean. Some of them lose a lot of lung function, others don't lose at all. So as a population, as a mean, they go down. But it is a very sobering fact that asthma can lead to loss of lung function, and when it does happen, it happens early on in life. The other thing that's very interesting is that you now follow these persistent wheezers up till the age of 17. Now they're parallel to the control group. So they don't continue to lose lung function. And I'm going to make that a little bit clear later on. So what it looks like is that you have this early insult in a developing lung, and that you lose that lung function, but then after that, once your lung is completely developed, you may not actually lose more lung function. You're just lower for the rest of your life. So that was, at the time, that was a very provocative concept. That was totally different from what we thought. And so here's another study that I think is really crucial to understand because it can never be reproduced. This is a study that was started, I think, in the 1960s. That was even before I was a medical student. And so this was done in Melbourne, Australia. And at the time, the researchers had the same question. When you look at a study, you always want to know what is the question. The question was, what happens to lung function in patients who wheeze? And at the time, they never considered that a 1 or a 2-year-old could have asthma, right? We used to think it never happens in infancy. So they recruited 7-year-old kids. And they recruited control who never wheezed, what they called mild wheezy bronchitis, which are kids who wheezed only with viral infection. And then what they called asthma were kids who wheezed even when they did not have a virus. 3 years within the study, they realized they didn't have anybody with severe asthma. So they recruited another group of severe asthma, but they took them at age 10 so that they could be the same age as the rest of the cohort. So what we're going to look at is the one question they ask, which is what happens to the lung function. Now, this was an age where there was no inhaled corticosteroid. These patients were essentially not treated, except with maybe theophylline or albuterol. And when they got an exacerbation, they got oral steroids. But they were not treated with chronic anti-inflammatory medication. And so this is as close to the natural history of asthma as we're ever going to get, because I'm showing you a population that's been followed for 35 years. It would not be ethical today to do a study where you don't treat asthmatic for 35 years. And so look what happens. This is the control. Here they are, in green up there. And then you have these wheezy bronchitis, which are probably the transient wheezers, right? And you see they have very normal lung function. And again, it stays normal through the age. Now, what we're looking at is FEV1% predicted. But look at the severe asthma group. Remember, they're 10 years old. And at 10 years, they're already significantly lower than the rest of the population. So again, just like we showed you in the Tucson, Arizona study, there was loss of lung function with severe asthma, not with mild asthma. And it had happened very early on in the first 10 years of life. But look over the next 35 years. These people aren't being treated. And they're not going further down. They're not going like this. So does that mean we should not treat asthma? Absolutely not. We should treat asthma because asthma can kill and it puts you in the hospital. But what I'm trying to tell you is that the reason why we treat asthma is not what we thought. I was taught that we treat asthma so we can prevent the loss of lung function. Well, you can't prevent something that doesn't happen. So that's another study. Well, let's keep looking. These are very, very different kind of concepts. And so we need to make sure that we're correct with that. But what they put together is a theory that Fernando Martinez published in the New England Journal that says the model is probably that kids with asthma are born with normal lung function. They get an exacerbation or 2 or 3, and early on when they have these immature lungs, that damages their lungs and they lose lung function. That actually is not what should be highlighted here. But these were the various lifetime models. And then, so they lose a lot of lung function. And then after that, you see that they don't continue like this. What they do is they're now parallel to that normal curve. Because guess what? After the age of 18, everything declines, including your lung function, normally. And so you do have a normal decline, but what you can see is that that curve is parallel to the normal curve, right? So the decline that happens afterwards doesn't seem to be due to asthma, it just seems to be due to age. So is this really what's happening? And if this is what's happening, can we stop that? Can we prevent that loss of lung function? Okay? So the studies that I'm going to show you are mostly sponsored by the National Institute of Health through a network of universities and practices that actually get funded to do these kinds of multi-center studies. None of these are pharmaceutical-sponsored studies. So the big question is that if we lose lung function with asthma, can we prevent that? And the gold standard medication that we have for the treatment of asthma is inhaled corticosteroid as an anti-inflammatory, because we now understand asthma as being a chronic inflammatory disorder. So can that prevent the loss of lung function? And so what I'm going to show you is the CAMP study, the Childhood Asthma Management Program. Has any one of you read about the CAMP study? Because that is a must-read for pediatricians who treat kids with asthma, which is all of you. So the Childhood Asthma Management Program is ongoing, and it is a multi-center NIH-sponsored study that took over 1,000 children, ages 5 to 12. Again, that was started in the 80s. We now know that asthma most of the time starts in the first 3 years of life. But at the time, they figured they were being very progressive by taking 5-year-old kids and putting them on inhaled corticosteroid. So they were 5 to 12, and they randomized them to receiving an inhaled corticosteroid, in this case budesonide, versus a matching placebo, or nidocromil, which is kind of like a cromolyn sodium compound, which at the time was a favorite for treating asthma in children. I don't think you guys use that very much anymore. And that study went on for 4 years. Now, you see that the kids were on placebo. And so, of course, if they had exacerbation, they were treated with oral steroid. And if they had more than 2 exacerbations, it would not have been ethical to keep them on placebo. They would then be put on inhaled beclomethasone. So the placebo group is a little bit contaminated by kids who had exacerbation and got some beclomethasone, but not nearly as much as the kids who received the inhaled corticosteroid versus the cromolyn. 4 years. So these are long-term studies. These really should give us answer. Now, the question that the investigator asked, remember, always ask what's the question, was not do inhaled steroids work? We all know they work. We know they're wonderful. They really control most of our kids with asthma. They prevent them from going in the hospital, and that's exactly what they saw. The question they were asking is what happens to the growth of the lung. But sure enough, you can see that if you compare the urgent care visits, the group treated with budesonide is in the light blue, and you have the lowest number compared to placebo. Lower number of hospitalization, almost cut in half. Lower number of oral prednisone use. None of that is very surprising. They also did methacholine challenges, which measures the underlying hyperreactivity of the airways. And what you see is the group treated with budesonide actually did very well. The higher this, the less reactivity you have. So you can see that over the 4 years that you're treating your kids with inhaled corticosteroid, what you expect happens, which is you decrease the inflammation, you decrease the hyperreactivity. But you also see that once you stop and you bring them back 4 months later, they go right back to baseline. And so we know that. We know that inhaled corticosteroid work great as long as you use them. They don't cure you. They don't cure asthma. You can't stop them. And you can see that the cromolyn and the nidocromil and placebo really didn't do very much. But what was the question? What happens to the growth of the lung? So how do you measure lung growth? You measure spirometry, you measure FEV1, but you do it after you've given the patient albuterol. Because what you want to know is what is the maximum FEV1 that you can get out of that patient. So it's very important to keep that in mind. This is post-bronchodilator FEV1. This is not the same thing that was measured in the Melbourne study. Okay, so what do we get here after 4 years? Placebo is in white, nidocromil is in green, budesonide is in pink. So you get this little blip early on. You notice they're all starting very nicely, right? They're all above 100% predicted as a mean. And there's absolutely no difference at the end of 4 years between the 3 groups. So what does that mean? Does that mean we should put our kids on placebo? Absolutely not. Remember all the data I showed you on efficacy, right? Half the number of hospitalization, urgent care, no. It means the inhaled steroid worked beautifully well, but it didn't seem to have an effect on the growth of the lung. Now, I know what you're going to tell me. You're going to say, well, wait a minute, they were 5 to 12. You just told us that loss of lung function happens in the first 6 to 10 years of life, so maybe you were too late. And you're also going to tell me, but there's no loss of lung function after age 5, so you can't prevent something that doesn't happen, right? And so these investigators really were very surprised by the data, and they decided to go and dissect it. And the data I showed you earlier is mean data. It's not every single child in that study, it's the mean. So they said, we know there are some kids in there that are losing lung function. We're going to go look for them. And they went and they looked for them, and they looked at every individual child. And if the child lost more than 1% FEV1 per year post-bronchodilator, they called it SRP, for significant reduction in post-bronchodilator FEV1. They found them. But you know what? They were about 20, here they are in red. And you can see they're losing lung function. They're about 25% of that population of 1,000 kids. So they got buried in the mean. You couldn't see them when you just looked at the mean data. But you can certainly see them now. So what we want to know now is, okay, well, we know ICS is not going to change the lung function in this group because they're not losing lung function in the first place. But what about this group? What happens if you look at the effect of budesonide just in the group that loses lung function? Nothing. If you look at the percentage of kids who lose lung function, they were about 25% in all 3 groups, whether they were treated with budesonide, placebo, or nidocromil. And they still didn't give up. They said, okay, well, maybe the rate of loss of lung function is lower. It's not any different. So what have we learned? Inhaled corticosteroid work beautifully well to control asthma. There is a group of kids that are predestined to lose lung function, and we need to learn more about how to identify these kids. But right now, today, with what we have on the market, we can't prevent that loss of lung function. And that was a very, very sobering information, because it meant that the reason we treat is to control their disease, not to prevent loss of lung function. So if their disease is controlled, then we cut back. If their disease is not controlled, then we increase. That's really what determines how much inhaled corticosteroid we give them. So you did tell me, right, that it was too late. Those kids were 5 to 12. Okay, so the next step, you can see the logical progression of these studies, and I think this group is doing just absolutely marvelous work that has given us a lot of information about childhood asthma. So the next study is the PEAK, and that stands for early asthma in kids, preventing early asthma in kids. So these kids are now 2 to 4 years old. And now we're getting braver. We're saying, we know it starts early, let's take these young kids. How do we identify 2 to 4 year olds? We use the Asthma Predictive Index, and that's how they recruited them. They had positive Asthma Predictive Index, and they were recruited and started on placebo versus an inhaled corticosteroid. In this case, they used fluticasone, meter dose inhaler using an aero chamber with face mask. Now, I'm going to show you some data, and some of you skeptics are going to say, well, wait a minute, 2 and 3 year old, they're not getting their fluticasone in the lungs. Well, they were, because they measured growth velocity and it went down. So they were definitely getting some. So let's look at the design of the trial. You bring them in for a run-in period, and then you randomize them for 2 years. During the 2 years, you're measuring how well they're controlled, and at the end of 2 years, you stop. Because what you're asking is not, does it work, does fluticasone work in asthma? We know it does. You're asking, these kids have a high risk of developing persistent asthma. If I treat them really early on, can I prevent that? Can I make them not develop persistent asthma? And can I change their lung function? And here's the data. So if you look at the first 2 years, just as you would expect, fluticasone worked beautifully well. Here we're looking at symptom-free days. And you can see that if your 2 and 3 year old with high risk for asthma is on fluticasone, they do very well. If they're on placebo, they're not doing so well. You stop the treatment at the end of 2 years, and within a year, you continue for a 3rd year, and within a year, your fluticasone group is just the same as the placebo. Same concept. Inhaled corticosteroid work beautifully well. As long as you use them, you can't stop them. You don't cure anything. Unfortunately, the 2 years did not prevent these kids with a high risk for asthma from developing asthma. Now, I'm not showing you the data, but they did some lung function, some infant-type pulmonary function tests, and they saw no difference in the 2 groups either. So you see that it's not one study, it's not 2 studies, it's many studies. It's very well done studies, prospective studies, looking long-term, and they're all kind of saying the same thing. So what we have learned is that some children lose lung function. The majority don't. And that's actually a very positive message for parents. If you have mild asthma in childhood, you're going to have mild asthma as an adult. But if you have severe asthma in childhood, that is somebody that you're going to need to follow very carefully their whole life. And unfortunately, we don't have the ways to prevent that loss of lung function that this subgroup is getting. So what we need, just like we got the API to identify who's going to continue to wheeze, we need some better predictors of who's going to lose lung function. And then we need to understand their biology better. What is it? What cytokine? What is going on? Why are they losing lung function? And then we can potentially develop some therapeutic agents. Okay, so the next study is going to be, can we predict who's going to remit, who's going to persist even after the first 6 years of life? And that's still the CAMP study. We now call it the CAMP continuation study. So after the first 4 years of randomization, these kids were then sent back to their primary care physician for treatment. So we're not controlling the treatment. They're being treated with whatever their physician is giving them. But they're continued to be followed for a range of 7 to 10 years and a mean duration of 9.3 years. And you're collecting the treatment. And what you're looking at is asthma activity, which is any contact due to asthma. You call it you call it remitting asthma if they've had no asthma activity in the previous year. You call it persistent asthma if they have asthma activity at each of the visits. And you call it periodic asthma if it's all over the place, some visits and not others. And then you go back and you look at their characteristic and you say, well, how many of them go into complete remission and how many persist all the time and how many are in between? And once again, you can see that the numbers that remit are very small. So if you have persistent asthma, you're not likely to outgrow your asthma. But remember, the 60% of the babies under the age of 3 who are wheezing with viruses aren't going to wheeze by the time they're 6. Not because they outgrew their asthma, but because they never had asthma in the first place. So we can still give that positive message. If we see the child who doesn't have eczema, who doesn't have food allergy, and who's wheezing with viruses, we can say your child has a 60% chance of not wheezing at the age of 6. Not because they're outgrowing their asthma, right? But if we see the child who's got eczema, who's wheezing, mom and dad have asthma, they have food allergy, we need to be realistic. We need to say your child has asthma, but we can control it. And we can have this child lead a perfectly normal life. We have great tools to do that, but we can't stop. You need to take that seriously, and you need to treat long term. And then in terms of actually predicting that, we're not very good at doing it. If you look at that, the major predictive factor is sensitization. So if they're sensitized, then that's a good prediction that they're going to continue, which is that first graph I showed you. The allergic kids are the one that really continue to wheeze into adulthood. And of course, there are different phenotypes. There is adult onset asthma that is not allergic, and not everybody is allergic, but that is one of the best predictor of persistent wheezing. So I told you earlier, the data I'm going to show you is not going to really change what you know already, which is the medication that we have available to treat asthma. It's just going to make you think differently about why you treat these patients. So really what you want to do now is control the disease. And that was the whole emphasis on the most recent set of guidelines from 2007. And if you remember, it was not so much about is your asthma mild, moderate, or severe. It was more is your asthma controlled or not, regardless of whether it's mild, moderate, or severe. And so that really is going to be our major push. So this is the current guidelines that we have. You've all seen them, right? You all know them very well. And we have them for 0 to 4, 4 to 11, and then, or 12, and then above 12, because the FDA approval for the various medication changes a little bit with the age. But essentially, what I'm showing you is not mild, moderate, severe. I'm showing you control. Now, for years, we all know that rule of 2, right? So if our patient is wheezing more than 2 days a week, and if they're waking up more than twice a month or more, and if they're having albuterol more than 2 days a week, they're not controlled. And that's true. But what we've added to this is that. So how many of you see kids that do pretty well, and then they get an exacerbation and they're in the ICU? In the old guideline, they were classified as being mild because they weren't wheezing twice a week over the past year. Well, you're not mild if you end up in the ICU intubated. So what it was is that the previous set of guidelines really was not taking into consideration the exacerbation. And so in this, control is, yes, you're not wheezing all the time, but you also don't have exacerbation. And you can see that not well controlled is as little as 2 exacerbations a year. Now, this is a US guideline. I can tell you the European guidelines, and I kind of agree with them, had 0 here. Well, what do you mean 1 exacerbation is good control? You shouldn't have any exacerbation. But, we'll see what the new guidelines show. It'll be interesting. But there is a lot of concern about, is it the exacerbation that is causing the loss of lung function in this subgroup that keeps on losing lung function? And there's a lot of research going on into that. So when you're looking at asthma control, don't just focus on are they wheezing twice a week. Look at how many times they're having exacerbation. And I can't tell you how many times I've had resident at my institution present a case and tell me, oh, the child is very well controlled. They only got 2 courses of oral prednisone this past year. No, in my book, if they're well controlled, they're getting 0 courses of oral prednisone this past year. So same thing for 5 to 11, and then, so how do we treat them? Well, this is the current guidelines, right? And again, I'm not teaching you anything here. You all know that. So we have these dogmas where we say that we prefer this, but we have this alternative, and then if you don't respond, we increase the dose. And if you don't respond, we now add 2 things, and if you still don't respond, we keep adding. And if you're a little bit older, we can now add LABA, long-acting bronchodilators. And if you're still a little bit older, we can add Xolair, a monoclonal anti-IgE antibody, and we really reserve oral corticosteroid for the rest, for the total failure. So this is very well if you put everybody in a box and you say everybody looks the same. And a couple of times now we've talked about the mean and the bell-shaped distribution. So why do we prefer one medication over the other? Well, when you put these guidelines, you have to go by some data. And the data says that if you take 100 kids, more of them are going to do better on inhaled corticosteroid than on a leukotriene modifier. But not all of them are going to do better. So we put the guideline based on the best percentage. But if we want to really get to the area of personalized medicine and we want to do the best treatment for that one child, we're going to start thinking about disease heterogeneity. This is an amazing study that was done again by this network, and it's authored by Bob Lemensky, who's the current president of the American Academy of Asthma, Allergy, and Immunology. And he called it Badger. I forget how he managed to do Badger. He's in Wisconsin. But what he did is, so the big dilemma for pediatricians is you've got a child with asthma, and you've put them on low-dose inhaled corticosteroid, and they're not controlled as well as you'd like them controlled. Now you get to step 3 of the guidelines, and so what do? You have options. You can double the dose of steroids, you can add montelukast, or you can add a long-acting bronchodilator. Which one do you pick? And how do you pick? So he was hoping that he could figure this out. And so his group engineered this trial, which took children with uncontrolled asthma on low-dose ICS, and they did a 3-way crossover trial, meaning each child was their own control. Each child went through the 3 different potential addition. Okay, so and there was there was a run-in for 8 weeks, and then there was 16 weeks of each treatment. Okay, so you're a young child on low-dose ICS, you're not doing well, you come in, you might get started on doubling the dose of steroids. You do that for 16 weeks. Then you go on and you do adding a leukotriene modifier. You go back to the first dose of inhaled steroid, and then you go on to the 3rd arm and you add the LABA. So every child got all 3 mixed up. And then at the end, you're measuring everything. You're measuring lung function, you're measuring quality of life, you're doing the asthma control test. You're also measuring inflammation marker, exhaled nitric oxide, etc. The most impressive part of the study was this point, is 98% of the children in that study did better on one versus the other 2. Meaning there was tremendous heterogeneity. And indeed, one was better than the other 2 for each child. So which one was better? Well, again, we go back to these numbers when we try to lump everybody together. And if you compare adding a long-acting bronchodilator, LABA, versus ICS, by ICS we mean doubling the dose of inhaled steroid, you see that the LABA looks better in about 50%. But look at this one here. Actually doubling the ICS was better in about 35%. So when you're going to write guidelines, you're going to say, well, we recommend that you add LABA because more of the kids did better. But when you do that and you apply it to everybody, you're not helping these kids. They did better when you doubled the ICS. So I want you to keep this in mind. When you have guidelines, that's exactly what they are. They're guidelines. You may choose to start with adding a LABA, but then make sure that you're reassessing control. If they're not controlled, don't say, oh my God, what am I going to do? That is the preferred. Go back to the other ones. That child might be one that responds better to doubling the dose of inhaled steroid. Look at that. This is LABA versus leukotriene. So LABA was better in 50%, but look at that. Adding montelukast was actually better in 35%. And if you compare doubling the ICS versus adding the leukotriene, they're about the same. Does that mean that leukotriene are as good as steroid? You can't generalize. It's for that patient. And 98% of the kids in this trial did better on one versus the other 2. The point of this trial is individual decision, is heterogeneity. And unfortunately, we don't have markers yet. The authors of the study tried to find the markers that would tell us who responds better to LABA versus steroids versus Montelukast, and they really couldn't come up with a lot. Except maybe, it was very interesting, the race or the ethnic group, because if you look at that, you can see that in the African American population, actually doubling the inhaled steroid was similar to LABA. And we have a lot of data that says, they may not work as well, the LABA may not work as well, but nothing that you can really take home and say, this is how I'm going to figure it out. Now, I could tell you today, we have measurements of exhaled nitric oxide, which is a breathing test, which indirectly tells you if the child has eosinophils in the lungs or not. And if you have a child with a very high ENO, meaning they have a lot of eosinophils, number one, they're not taking their inhaled corticosteroid, which is a major reason why they're not controlled. Number two, this is absolutely a kid that you increase the dose of inhaled steroid to. So we're starting to get some markers now that tell us when to do one versus the other. If you have a child who, on lung function, the exhaled nitric oxide is normal, but you give them albuterol and you repeat the lung function, it goes up by 30%, they have major reversibility. They're probably going to do very well if you add LABA. So we're starting to get some clues. But the point of the study is to tell you that every child is an individual and that there is distribution of responses, and that in general, inhaled corticosteroid are the best for most of the kids, but not for all of the kids. And it's true for the adults as well. And so these were the conclusion of the study. Like we said, 98% had a differential response. The LABA was more likely to provide the best response, but many children had a best response to ICS or leukotriene. So this was published in the New England Journal, and then the editor of the New England Journal decided this was such an important study, he himself wrote the editorial. And he wrote the editorial, and stories around studies like that are really what makes you remember these studies. The editorial almost started a war, because the editorial said, since some children are going to do better on leukotriene modifier, it's a pill, it's not a steroid, we think it's a good idea to start with that and then assess control. And if they don't respond, then you can always increase your steroid or add the LABA. And that absolutely created havoc. Because, of course, the guidelines said it's better to add the LABA. And the study said LABA is better in 50%. So I felt very good that the editor of the New England Journal of Medicine felt that it was okay for him to interpret the data and devise his own personal approach to it. So essentially, the message I'm giving you is that you have a choice. Choose what you think is best for that family, for that patient, and then reassess control. If your patient is controlled, you have taken the right choice. If they're not controlled, it's time to change. Okay. Step down. If they're controlled, it's time to go down. And I think I'm going to pretty much summarize my talk. So what I really would like you to take home from this presentation is this Asthma Predictive Index, which is a tool that you can use in the clinic to help you make decisions. When I see a child with a negative Asthma Predictive Index, I am much less likely to put them on chronic therapy and more likely to observe them and then reassess how they're doing. If I see a child with severe eczema and mom and dad have asthma, I'm going to start them on chronic therapy. That child clearly has inflammation in the airway. So it is very helpful. Disease progression, remember, some of your patients are going to lose lung function. Most of them are not. You still want to treat them because you want to prevent them from losing time at school, from the parents losing work, from ending in the hospital, and from dying. So don't take my remark as placebo is the same as ICS. It's not. It's just that ICS does not change the course of progression of the lung function. And finally, when you talk about disease control, when you're thinking about your treatment, think about control and always reassess the control, and think about disease heterogeneity as you're trying to decide what is the best therapy for your patients. So I'm going to stop here, and I think we may have a couple of minutes for questions. Yeah.
help us differentiate between the ones who are wheezing from an asthma versus
Right.
those who are
Right.
wheezing from bronchiolitis with regards to albuterol itself.
Absolutely. So I think that it can help you because, you know, in our young children where we can't do normal lung function testing and stuff, the response to albuterol is very important in making your decision as to what level of the airway is affected and what's really affected. So in older children, I actually do a before and after albuterol spirometry, and that helps me a lot make a decision. So the clinical response to albuterol is important, but what I'm going to predict is that your patient with a positive asthma predictive index are likely to respond to albuterol, while your patients with a negative API are likely to not respond. And the difference there is that if you have, the problem is that in kids with asthma, in that age group, 90% of the asthma exacerbation are precipitated by viruses. So it doesn't differentiate them that it's a viral-induced wheezing. It still could be asthma. If they have an asthma predictive index, then they're likely to be having asthma and they're likely to respond to albuterol. If they have a negative API, they're very likely to not respond, and it's something that I actually ask in the clinic. I'll ask these parents, do you notice any difference when you give the albuterol? And of course it's subjective, but oftentimes the answer is no, not really. It doesn't seem to help. And so I think that it'd be very interesting to follow up on that. But I would say that yes, it would be helpful.
So I have a sort of follow-up possibly this Jennifer's question. Like you said, the guidelines here are 0 to 1 exacerbation if they're fairly well controlled, 2 to 3 if they're not as well controlled, if they're somewhat controlled in water. What would be your recommendations for a child who has limited asthma, but then ends up in the hospital with one big episode in winter needing a corticosteroid or an anti-steroid? Would you automatically then bump them up to cortical status and put them on an inhaled corticosteroid, or do you give them like a one pass, say, you're okay, this is the first time you've done it, let's see if you have more this winter, then you get
Yeah.
on inhaled corticosteroid?
So it depends on the age of the child. And so if I was designing that slide, I would keep the 0 to 1 for the kids under the age of 3. Because of what we just talked about. Because some of these kids with viral-induced wheezing, they have pretty small airways. They really get into trouble. They need oxygen. That doesn't differentiate them from the real asthmatics. And if they don't have inflammation, the steroid is really not going to help them. In that age group, I think that if they have a completely negative asthma predictive index, I might follow them. I haven't covered that because of time, but there are a number of studies now. There was one specifically by the same net of NIH investigators that looked at starting high-dose inhaled corticosteroid at the onset of a viral infection and using it for 7 to 10 days and comparing that with treating the child year-round with inhaled corticosteroid. And what they did is they treated the kid for 1 or 2 years, I forget, but they did not see a difference in the number of exacerbation at the end of that time period, whether they treated year-round with nebulized budesonide in that study or whether they used 1 milligram twice a day, so really high dose, but just for 7 to 10 days, which they started at the onset of the virus. The problem with that study is they didn't have a placebo group. So they recommended to do the high-dose inhaled steroid at the beginning of the cold, which I often do as a kind of in-between. But you wonder whether the placebo would have done as well and whether we don't need to do anything. But certainly we know, and they justified that by saying there are other studies that have done placebo versus high-dose inhaled steroid during a cold that have showed a significant difference. So I would tend to do that for that child. I would tend to start high-dose inhaled corticosteroid at the onset of a virus and use it for 7 to 10 days and not put them on chronic year-round inhaled corticosteroid if their API index is negative. If their API index is very positive, I tell you, if they have severe eczema and food allergy, personally, I'm treating them because what that child is telling you is they have eosinophils everywhere. They have it in the skin, they have it in the lung, they have it in the nose. In my clinic, I tend to do nasal cytology, where I scrape the nose and I look at it under the microscope. Unfortunately, this is falling out of favor. But it's very helpful because I see right away whether the child has eosinophils or not. And I see it a lot in these kids with severe eczema in the first few months of life. So to me, that's an indirect exhaled nitric oxide, if you will. And so I tend to be much more prone to starting them on inhaled corticosteroid if they have that. If they don't, then I think it is reasonable to wait for 2 or 3 exacerbations. Now, once they've had several exacerbations, we all tend to put them on inhaled corticosteroid year-round. And you know, for those transient wheezers, it still doesn't help, but we're doing the best we can. We're trying to figure it out. The important thing is to reevaluate. Because if they go for a year without having any exacerbation, step down and ultimately take them off. They could have been transient wheezers all along. But I would give this child a pass if they're young. Now, if this is a 6-year-old or a 7-year-old, then the chance that this is viral-induced wheezing is very, very minimal. So in the infant, yes. Anybody else? All right, great. Well, thank you so much for your attention today.